Hello, good morning. Hopefully, I'm live on the internet now on Facebook. Welcome to Saturday morning Coffee and Crumpets with Dr. Childress. I'm planning to hopefully just make this sort of a regular thing where I'll just drop in on Saturday mornings and talk about some aspect of something. Today, I'd like to action needed. Oh yeah. So something may be going wrong. But today I'd like to talk about treatment plans. Uh, and I'm going to start with giving you a little background on just sort of my credibility to speak about treatment plans. Um, a treatment plan is something you should always have from your doctor, from your mental health professional. That's a second here. Uh, Something says I need to do something. Uh, so we'll see if that works. Um, so my background in developing treatment plans or in working with them is throughout my career as involved in psychology, but also um, that when I was working at Children's Hospital of Orange County, they have a internship there, an APA approved internship as well as a postdoc. And I was a supervisor in their APA internship and postdoc training. So I trained the mental health people, psychology people, in developing treatment plans and diagnosing the pathology and so forth. And then I moved over to my own clinic. It was a 3 university clinic. There was University of Redlands, who provided speech and language services. Um, There was Loma Linda University. They provided occupational therapy, which is the sensory motor stuff. And then Cal State San Bernardino provided the psychology staff. And I was brought on as the clinical director for the entire project. So I also know about all the sensory motor stuff, and I know about speech and language, and I was kind of coordinating it all for early childhood, 0 to 5, in the foster care system. So Child Protective Services would remove a child into foster care, and then they would send them to our clinic for the assessment and treatment. And so, children 0 to 5 can't always tell you the history about why they are the way they are. So we kind of had to figure out what sort of traumas they've been exposed to and prenatal drugs and those sorts of things. But more importantly, what are we going to do about it? Because the reason we need a diagnosis is to develop the treatment plan. Treatment for cancer is different than the treatment for diabetes. I find it amazing that I have to keep saying that over and over again, but it's just, it's the treatment for cancer is different than the treatment for diabetes. You need a diagnosis to guide your treatment plan. That's one of the big problems over here in forensic psychology because they don't diagnose what the pathology is. They don't identify what the problem is. And if you don't know whether it's cancer or diabetes, which one are you treating? So treatment always starts with the diagnosis. Diagnosis guides treatment. That's like just basic in all of healthcare. Diagnosis guides treatment. You tell me the diagnosis, I'll tell you the treatment plan. Pretty much for anything. If it's ADHD, we got ADHD treatment plans. If it's autism, we got autism treatment plans. Trauma, we have trauma treatment plans. So what's the diagnosis? In this case, in the family courts, the diagnosis of concern is a shared persecutory delusion, and that would be child psychological abuse. If we have child psychological abuse, the treatment plan for that is to protectively separate the child from the abusive parent. So, that's kind of important. The forensic psychologists over here, because they don't diagnose pathology, which will get them into a lot of trouble, and but then they don't they don't diagnose the child abuse. And so no treatment plan they develop will be effective because it's a misdiagnosis. the diagnosis is child psychological abuse and a shared persecutory delusion. If you misdiagnose that as diabetes, you wind up treating cancer with insulin, and the patient will die from the misdiagnosed and untreated cancer. So that's a lot of what I'm doing right now, is encouraging them to develop an accurate diagnosis for the pathology. The issue with that is currently the forensic psychologists are simply not motivated to change. They're getting lots of money and they're just doing what they're doing, and there's no motivation for competence. That goes back to the licensing boards. And all the rest of psychology, autism, ADHD, trauma, eating disorders, substance abuse, the licensing boards ensure professional competence. Over here, in the court-involved stuff, they are nowhere to be seen, which is why the standards are so incredibly low over here. So I'm doing it on my own, just holding my professional peers accountable for professional standards of practice. A lot of people will, or the pathology at least, will say that Dr. Childress has some sort of new theory, this attachment-based parental alienation. No, that's not true. I specifically avoided anything new because I needed to get past the fight and Daubert and all these other things. So there's nothing new about anything I say. And the book Foundations, where I describe everything, is actually a diagnostic treatise. It is a diagnosis. And so I explain why the diagnosis is what it is. But the diagnosis is a shared persecutory delusion and child psychological abuse, sometimes bordering on factitious disorder imposed on another, Munchausen by proxy. So that's the first element of a treatment plan, is to ensure you get an accurate diagnosis. And then once you have that, you develop the treatment plan for that. And the interns were at my clinic. We just switched over to these new computer-based charting systems that were wonderful. And so they would send me their intake assessments, their chart notes, their treatment plans. And there were standards we had to meet for county. We were county funded, so county's pretty tough on their standards. So we had standards to meet for diagnosis and for our treatment plans and for our chart notes. And the treatment plan needs to address each element of the diagnosis. And our chart notes need to chart to the diagnosis and treatment plan. If we don't, then that chart note or that entire case, if the treatment plan is a problem, it will be invalidated on the audits. They do random audits. And so they come and take a look at 10 of our charts or 20 of our charts. If they find that 10% of our charts have some sort of failing, and so they pull the funding for those notes, they will pull it for 10% of all of our funding. And oh my God, we got to pay back 10% of our funding because we have a messed up chart note or a messed up treatment plan. It can be something as simple like if you put a rule out or provisional on your intake assessment, that has to be cleared within 4 to 6 weeks and get a firm diagnosis. If the Department of Mental Health comes in for their audit and you haven't cleared and formalized your rule out or provisional diagnosis, they will disallow all of the funding for that case from there on out. So you could have 6 months of treatment that was just disallowed for funding because you didn't clear your rule out diagnosis. So it's very precise. And here's what a treatment plan should look like. And you can Google this. It's really simple. Google mental health treatment plans, and you can see them right up front. On Google, WikiHow offers a little, explanation of treatment plans. And so it's standard of practice everywhere. You can even Google or go to Amazon and do mental health treatment plans, and they have like template treatment plans for family pathology or for child and adolescence, and you just templates. Now those book templates from Amazon is what I might give an incoming intern, a pre-doctoral intern. I wouldn't expect a postdoc to be at that level. I expect them to be higher. But for a pre-doctoral intern with ADHD or autism or school behavior problems, that sort of thing, those Amazon template treatment plans, they'll work. But it should be better. Um, and uh, so with a treatment plan, there are four elements that are uh, essential and expected. The first is we want to identify measurable goals. They must be measurable because we will be measuring whether or not we achieve those goals. So it might be to reduce the child's um, uh, getting out of their seat during class from four times during the school day to once during the school day. So, we have something, a measurable way of saying progress towards that goal. And typically we would have about three goals, not more than five. I call them bullet points on the thing. What are the bullet points that we're addressing? So we identify 3 to 5 goals that we want to accomplish with that are measurable. The next is we have to identify specific interventions for each goal. Specific, not general. Specific. What are we doing to address that goal? So specific interventions for each goal. And then the third is time frames for goal accomplishment. What do we anticipate? Is it going to be 3 months before we reach this goal, 6 months before we reach this goal? Oftentimes we add benchmarks in between. Now, if you want to see an example of this, look to a school IEP. That's a treatment plan. They have goals that are measurable. They have interventions to address those goals. They have timeframes for doing that. And they have outcome measures. And that's the fourth element. And that's really, really important, the outcome measures. And that's not done anywhere over here. Because how do you know if you're making progress or achieving the goal if you're not measuring it, if there's no outcome measure? And the other important thing about outcome measures as a supervisor is I would anticipate in my clinic that I'm going to see beginning change within the first 2 weeks. Okay, so I want to see something hitting the outcome measure within 2 weeks. 4 weeks, by 6 weeks, I should be seeing something. If I'm not seeing not significant, but substantial movement associated with that treatment plan and those goals by 6 weeks, then I'm going to reevaluate everything. I most likely have a misdiagnosis. If my treatment's not working, it's most likely a misdiagnosis. If you come into a physician and you got some sort of problem, the physician gives you medication for the problem and the medication doesn't do anything, you've misdiagnosed the pathology, because if that's an accurate diagnosis, the medication or the treatment should work. So if I have an accurate diagnosis, I would expect to see changes within about 4 to 6 weeks. I'd like to see the beginnings at about 2 weeks off of a treatment plan for the whatever it is we're treating. And there's a number of other important reasons for having outcome measures besides misdiagnosis and monitoring progress towards treatment. And one of the important things is that anytime we start to measure something, we will change it. We will be just simply because we're attending to it. If we attend to something negative, we will tend to increase that. If we attend to something positive, we will tend to increase that. So we want our treatment goals worded in positive ways, and our outcome measures looking at positives, so that as we attend to it, that will start to increase. Just simply because we're attending to it. It's called reactive reaction or something. There's a research term for it. But every time we start to look at it, we change it. Now, when I came over here, I developed a lot of instruments, the diagnostic checklist, the pathogenic parenting practices rating scale, because those are going to be needed by the surrounding mental health people to get an accurate diagnosis on things, and they're not competent They're not competent in attachment. They're not competent in delusional thought disorders. They're not competent in family systems. They're not competent in complex trauma and child abuse. I am. Okay. So I got competence in all of those. So once things change, once we motivate them to abide by the APA ethics code, they are all in violation of standard 2.01, which leads to a violation of 2.04 and 2.03 and 9.01, and just cascades off the fact that none of them are competent to be doing what they're doing. So that's going to create a crisis over here because none of the people are competent and they don't care. They're not motivated to care. So there'll be a little transition period where they are trying to become competent. So that's where all that diagnostic checklist and parenting practices rating scale and the outcome measure of the parent-child relationship rating scale all come into play. That I'm basically giving them the tools that they need based on my experience. I'm an old guy, worked in a lot of settings. I know the pathology. And so I'm holding their hands and scaffolding them from their incompetence to the period of their competence. But they don't care at this point. So they will at some point, and when they do, the instruments are there. But as parents, you can start using these things or recommending they use these things. It's really important for you parents to become informed consumers of mental health services because the forensic psychologists around you are the worst imaginable, and 70, 80, 90% of the time, they are participating in colluding with the child abuse because of their incompetence. The outcome measure that I recommend, it's an excellent one, is a parent-child relationship rating scale. You can go and get that on my website. There's a variant that I have that includes something about texting too. If the excessive texting is part of the issue, then there's a second version of it. And it looks at 3 items. Rates them on a 1 to 7 scale. 1 and 2 is awful, 6 and 7 is wonderful, 3, 4, 5 is normal range. We just want a 3, 4, 5. That has to do with a normal curve, and so we just have, most people are normal, a few are just wonderful, sometimes we get really awful. But we should expect to see everybody kind of, children in the normal range. The 3 items are affection, which are the attachment networks, cooperation, which are social regulation networks, and social involvement, which is mood and arousal. And so it's actually monitoring 3 brain systems: attachment, emotional regulation, and mood and arousal. But it's affection, cooperation, social involvement, and has anchor points for them. And it's excellent. It gives very good information from the parent. And the parent rates the child every day on those 3 items, emails them those ratings to the therapist. The therapist then puts those in an Excel file, and there's your outcome measure. Then at the weekly therapy sessions, you discuss the ratings, and the therapist will say, well, Johnny, you got a 2 here on Tuesday. What happened? And Johnny can explain what happened, and the parent can explain what happened, and the therapist can help them come to an understanding about what normal is, what average is, and help them negotiate and problem solve and communicate and repair any difficulties that occurred. And so it's a tool to help facilitate the repair and the normalization of parent-child interactions and things that's important in a delusional thought disorder. The child's distorted in their perceptions of reality. They can't trust the targeted parent because they're being invalidated. The pathological parent is giving them distorted information. So where do they get accurate information from? That has to come from the therapist. And so by using the parent-child relationship rating scale and looking at the actual behaviors and interactions, the therapist can give a normalizing perception to the child about what family interactions and expectations are in the family. So that's one use of the parent-child rating scale. The other important use is that in this pathology, we have what's called an inverted hierarchy, and you can see that in Mnuchin's diagram. The child is elevated above the parent to where the child is judging the parent as if the parent were the child and the child were the parent. That's called an inverted hierarchy. It comes from the cross-generational coalition and empowerment of the child. And so, to address that, to restore a proper hierarchy, the parent-child rating scale puts the parent back in charge of judging the child. So that reverses the inverted hierarchy of the dysfunctional family. Um, the the other thing that the um, parent-child relationship rating scale provides is that once we can see the child moves into normal range, but then on child abuse, there's a period of protective separation where we recover the child away from the abusive parent. But that's attachment pathology. We always want both parents and child receiving love from both parents. The only reason we would induce that level of attachment pathology in a child is child abuse, a child protection concern. But the moment we got the child protection concern under control, then we want to restore with the formerly abusive parent. We do that with physical abuse or um, sexual abuse is a little different, but physical abusive parents or neglectful parents, drug abusing parents, those types of parents. We will always seek to restore bonds, but when we do, we will put on some protective safeguards. For the abusive parent, it might be supervision. For the alcoholic parent, we get drug testing, that sort of thing. And then we gradually ramp up, and we would be looking at our outcome measures to see if the child abuse has returned. So one of the things we look at, symptom return for physical abuse, is if there's welts or bruises. And we say, whoops, the child abuse has started up again. In psychological abuse, the symptoms are emotional and behavioral, and relationship oriented. And so affection is going to be hit, emotional regulation, and social involvement. All of those are symptoms that will be impacted by psychological child abuse. So once we recover the child's normal range functioning with the targeted parent, 3, 4, 5s, then we can now move into restoring with the abusive parent with the safeguards to ensure that the child abuse does not resume. And we'll typically, for older children, we will tell them that all they have to do is maintain 3, 4, 5, and everything's okay. Okay, everything's going to just be normal if they are normal. However, if their relationship with the targeted parent drops to 1 and 2s again, then we're going to know that the other parent is starting into the psychological abuse. So when we restore with the other parent, you just keep doing what you're doing. You just stay normal, 3, 4, 5s, and everything's going to be okay. And what that does is it gives the child a chance to communicate to us what's going on over there without ratting out the other parent, without destroying their loyalty bond to that parent. That the child doesn't have to tell us what that parent's doing. If the parent wants the child to collapse into symptoms, and the child does, they are communicating to us that they can't handle that parent. It's too overwhelming. If the child stays normal, then no matter what that parent's doing, the child is communicating they're handling it okay. And so that's another important role of the outcome measure, the parent-child relationship rating scale, is to provide a treatment intervention with the child, saying, just stay in here, stay normal, and everything's going to be okay. And it helps communicate to the child that the parenting of the other parent is kind of problematic. And so, because right now the child's getting communications that parent's okay, and everything that parent's doing is okay. No, that parent's problematic. And once the child understands that and gets into therapy, they realize that what normal is, because the therapist is helping them with that. So just on the parent-child relationship rating scale, I just want to mention Dorsey Pruder has been using that to document her recoveries in the High Road workshop. And so her ABA single case design that she has, where she documents a 2-day High Road workshop that just rockets up to recovery, and then the post recovery phase with the maintenance care therapy. All of that was the parent child relationship rating scale. And so that's ratings from the targeted parent. So you know if the targeted parent's saying everything's okay, it's okay because they have no motivation to lie about that. So they're the parent's saying the child is recovered. And the useful thing about that, not only does it document that the treatment was effective, that the post maintenance care therapy was stabilizing the child, and that the high road workshop had recovered the child. So it documents that. But it also, once we restore with the other parent, if it drops and the child becomes symptomatic again, a relapse because the abuse has started up, you can take those Excel file into the court and say, look, Your Honor, had normal, all of a sudden we restore with the parent, boom, it drops back down again. Then if we protectively separate the child again, we recover the child, it pops back up. That's an ABAB single case design. It's considered the highest form of clinical intervention. It's combining research with a clinical treatment and data collection. And so it's just a clinical ABAB single case design is the highest caliber of clinical intervention. And I suggest that to be done over here too. It's easy piece of cake. Dorsey did it. Dorsey loves the ABAB. She thinks we should be using it all the time for assessment, and we can. We don't necessarily have to go through a lot of mental health stuff. We can diagnose based on treatment and treatment response, but it has to be done in a structured way. And so those are the four elements of a treatment plan. Specified, you have specific goals that are measurable, interventions for each goal specified, time frames for the goal accomplishment, and then outcome measures to measure whether you're successful on things. None of that is being done over here. Now, that treatment plan that I just described is the expectation I would have for an intern. For an intern, I would expect to see that. And if I don't, I'm kicking it back and saying, you need to improve this. And we don't have that for these psychologists or mental health people. We don't have that standard. So if you're not getting a treatment plan, you may want to suggest that the mental health person go on WikiHow and learn how to do treatment plans, because that's really scary that a licensed mental health professional is not at the level of WikiHow. So that's a problem. In order to get an effective treatment plan, we must have an accurate diagnosis. If we treat cancer with insulin, the patient dies from the misdiagnosed and mistreated cancer. The concern in the family courts, there's two. It's a differential diagnosis, one way or the other. One, we have attachment pathology. Only thing that causes attachment pathology is a problem parent. Attachment system never goes spontaneously dysfunctional. It's too valuable to survival. So one parent or the other is creating the attachment pathology. The two possibilities is that the targeted parent is abusive, thereby creating the pathology, the attachment pathology in the child. Then we specify what the abuse is, we treat it, bring it down, and restore with the child back in normal range. The other possibility, though, if that parent's not abusive, severely abusive, is that it's the allied parent who's creating the attachment pathology with the other parent. And we know what that is. That's a cross-generational coalition, emotional triangulation, cross-generational coalition, emotional cutoff. And it's through a shared persecutory delusion that then destroys the child's attachment bond. Here's how that works. The attachment system is a predator-driven system. It's the predators are trying to selectively target the children. And so the child stays close to the attachment figure for protection from the predators. It's an anxiety-based system. And so if I have a parent who's signaling that the other parent is a danger or threat to the child, that they've now defined that other parent as the predator rather than the protective parent. So now that child is going to say, oh, I don't want to go with a predator. I'm going to stay with the protective parent, who's signaling that I'm going to protect you and that other parent's a danger. None of this is cognitive. It's in the attachment networks. And so they're turning off the attachment networks towards the other parent by defining them as a false threat or danger to the child, that they have a wish to do evil to the child's being malevolently treated by that parent. And they are activating the child's insecure attachment to stay close to the supposedly protective parent. So that's what's going on with all the creation of the pathology here. And so we will need either way, one way or the other, either one parent's abusive or the other parent's abusive. But it's going to go either direction. On an attachment pathology this severe, a complete rejection, that's as bad as it gets. It doesn't get any worse than complete rejection of an attachment bond. So with that level of pathology, either the targeted parent's abusive or the allied parent is psychologically abusing the child by creating a delusional thought disorder that destroys the child's attachment system in childhood. So that's your differential diagnosis. That's what needs to be assessed, both halves of that. And both halves need to be documented in to get an accurate diagnosis. And documented in means that any mental health professional that reads your intake report and your assessment report should be able to follow exactly where the symptoms are and exactly why the diagnosis is and understand your treatment plan. For interns who send me their chart notes or intake notes and they give a diagnosis of ADHD, there's 9 symptoms of hyperactivity, 9 symptoms of inattention. If they meet 6 of 9 here, they have ADHD hyperactive type. 6 of 9 here, they have ADHD inattentive type. I want the intern to specify somewhere in there what 6 symptoms do they meet for that diagnosis, so that if I'm reading it, I can say, yep, okay, I see why that diagnosis is justified. If I can't understand why they made the diagnosis they did, that's an inadequate report. It has to do with continuity of care. Think if you had a cancer doctor and you go to a new cancer doctor and they say, can you give me your previous results? And they didn't do any testing, and there's no testing that shows cancer. It's like, holy cow, why did you make that previous diagnosis? And so as doctors talking to each other, we need to document in what the symptoms were that met the criteria for the diagnosis. Final thing, and then I'm gonna run away and head off, is that diagnosis is not an opinion. Okay, diagnosis is a very simple. It's a pattern match of the diagnostic criteria to the symptoms. If your symptoms meet the pattern match to the diagnostic criteria, that's your diagnosis, whether you like it or not. So if you meet patterns, your symptoms meet the pattern for schizophrenia, you got schizophrenia whether you like it or not, and you can qualify for service and get hospitalized and put on medications. I don't have schizophrenia. Yes, you do. You meet the criteria. So it's not an opinion. It's identical to what the judges do in the legal system, because we're both judges in our own systems. We're doctor judges, they're judges. And so they do the same thing. They collect their evidence in trial. We collect it in our clinical interviews. Then they apply the legal statutes, the wording of the legal statutes to the evidence. There's no opinion about what the wording is. There's no opinion about what the evidence is. Now, there might be an opinion about whether this particular piece of evidence matches this wording of the legal statute. And so there might be a question whether this symptom meets this diagnostic criteria. So the way we handle that in healthcare is you get a second opinion. You get another doctor and they say, does this symptom meet that criteria? But that's the only place for an opinion. The criteria are what they are. The symptoms are what they are. Listen to the criteria for a persecutory delusion. This is from the American Psychiatric Association. Persecutory type: delusions that the person or someone to whom the person is close is being malevolently treated in some way. Google malevolent, it's having or showing a wish to do evil. So, does the child have a fixed and false belief, delusion, that they are being malevolently treated in some way by the other parent, that the other parent has a wish to do evil? And now, if they do, if they have a delusion, fixed and false belief in supposed persecution, that meets the criteria for a persecutory delusion. If the child has it and the parent also has it, that's a shared persecutory delusion with the parent as the primary case. The parent or the primary case is also called the inducer by the American Psychiatric Association. So that's the diagnostic criteria that needs to be applied over here. And if you want specifically, you can get a rating on it from the Brief Psychiatric Rating Scale, one of the oldest, most widely used scales to measure psychotic symptoms. It's item number 11, unusual thought content. And so you can rate the delusional, how delusional it is based on the BPRS. I was trained for 12 years in the diagnostic assessment of delusional thought disorders to the authors of the BPRS, Joseph Ventura and Dr. Lukoff. So I'm one of the best trained people out there in the assessment and diagnosis of delusional thought disorders. And just generally, I would rate this as a moderately severe persecutory delusion, 5, because first, the child has full conviction, and that's defined as having acted on the false belief. So that's going to move it from at least to a 4 rating. If they've acted on the false belief, that indicates full conviction. That's a 4 rating. Now that would be an encapsulated delusion with no functional impairment. This is an encapsulated delusion, but there is functional impairment. There's functional impairment in the family, severe, and so that would kick it up to a 5. I've got functional impairment, full conviction, and it's a false belief. Or if it's a true belief they are being malevolently treated in some way, then that's a child abuse diagnosis relative to the other parent. So one way or the other, I'm coming back with a child abuse diagnosis. So I'm competent and I know how to do this stuff. They don't. So I've given them a diagnostic checklist for pathogenic parenting. They don't need to know the mental status exam if they can just do what I tell them to do. Those 3 symptoms, if those 3 symptoms on that diagnostic checklist are present, that this is absolutely the pathology. It's a shared persecutory delusion, no doubt. Then I've given them the parenting practices rating scale. To rate the targeted parent, let's identify whether or not they're abusive. And it's just a qualitative clinical assessment based on how you, asking them about how they parent. Level 1 is clearly abusive. Level 2 is almost abusive, really bad parenting. So those are your abusive range parents. And levels 3 is normal range problematic. I think that's most parents. And then level 4 is healthy parent, either a little on the structured side, a little on the negotiation side, or balanced using the 2. So 3 and 4 would be a normal range parent, and they couldn't be producing the pathology. So let's get clarity on what everybody's symptoms are. Gets clarity on the child's symptoms. Do they have an attachment pathology? That's diagnostic indicator 1. Are they showing excessive anger or excessive anxiety? Excessive anger is operationally defined as 5 narcissistic personality traits. Excessive anxiety is defined as meeting DSM criteria for a specific phobia, mother type or father type, which is bizarre and not realistic. And the third diagnostic indicator 3 is that the child has a fixed and false belief that they are being malevolently treated by in some way by the targeted parent. If those 3 symptoms are present, that's the pathology, a shared persecutory delusion, child psychological abuse. I give the diagnosis if those symptoms are met on page 2. You may want to look at page 3 too. Those are the associated clinical signs. Those are from me. Okay, and nothing else about this is from me. Those 12 associated clinical signs are from me because I know what the pathology is. And so I figured they're just so valuable that I just gave them to you, risking fight about, whether or not these, but there's reasons for each of those 12 associated clinical signs. One of the most common is number one. That's why I put it number one. Use of the word forced. If you see somebody using the word forced, the child shouldn't be forced to go on the visitations. We shouldn't force the child to do this or that thing. That's an associated clinical sign. There's a reason they use that word. Um, and then, empowering the child to reject the other parent, and it just goes on and on. Two of those associated clinical signs. Number three, that the exclusion demand, where the child says, I don't want you coming to my sporting events or graduation ceremonies or plays or things like that, excluding the other parent from activities. Associated clinical sign three is 100% diagnostic of the pathology. Just that one alone. If I have that associated clinical sign three, I know I'm going to get all the rest of them. The three diagnostic indicators: shared persecutory delusion. And the other one is associated clinical sign four, parental replacement. That's where the child starts to call the targeted parent by their first name or call the new spouse of the pathological parent as mom or dad. That doesn't happen with the attachment system. Nope, 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 nope. So if that's happening, there's outside influence on the child to do that. It only shows up with this pathology. So either ACS3 or ACS4 in the child's symptom displays will be almost 100% diagnostic. Clinical experience, it's 100% diagnostic. But you'll add research to that over the next 10, 15 years after I leave the planet. So with all of that, I'm going to head off to start my day. Thanks for joining me for Coffee and Crumpets with Dr. Childress on treatment plans. If you're not getting a treatment plan, give them Google searches that you've come up with and say, hey, how about this? Or give them WikiHow. Or have them consult with me. That's what they should be doing. They should be motivated enough that they should be acquiring this knowledge on their own. It's not my responsibility to educate them, and I should never, ever, ever have to educate a mental health professional in order to have a professional level discussion about the pathology they are treating. They should already know. I should not have to educate them first. That's a boundaries of competence issue. And I have to educate all these people. So it's a real nightmare mess over here. But I'll talk about how we can solve that later on. But you want a treatment plan. Let me end with this. The reason you want a treatment plan is because the pathological parent wants to drive this into the court system to put you on trial for being a bad parent, bad spouse, and to make it as hard as possible for you to see your children. And it's expensive. It's going to drain you of our financial resources. So there's a strategy there of driving this into the courts. You need to move this over to the healthcare system, to diagnosis. That's the Achilles heel of pathology, is diagnosis, identifying it. And so you want to move it over, you want a treatment plan. The other thing that does when you ask for a treatment plan, it puts the pathology and the other parent having to argue against treatment, and that will expose them. If they don't argue against treatment, then you get a treatment plan that gets a diagnosis and moves it on and fixes it, or they have to interfere with it, which exposes them again. The diagnosis, the accurate diagnosis here, is child psychological abuse, V995.51, page 719 of the DSM-5. This pathology is already in the DSM-5. So any mental health professional saying, we need to get this into the DSM, no, it's already in the DSM. It just takes the courage, professional courage, and backbone for the mental health professional to make the child abuse diagnosis. That other parent is extremely dangerous, and that's why they don't do it. They're afraid to challenge that parent, so they go along with the child abuse. My mental health people need to step up and start making a child abuse diagnosis when the child abuse diagnosis is warranted. Otherwise, that's a failure in their duty to protect. So that's where I am at right now, is whacking my professionals to get them up to speed. So you want a treatment plan to fix things. For that, you'll need a diagnosis. For that, you'll need a proper assessment. You need a proper assessment for possible child psychological abuse. You need a proper assessment for a possible shared persecutory delusion. And then you need a treatment plan to fix it. Goals, interventions, time frames, and outcome measures. So with that, bye-bye, and have a nice weekend, and we'll be talking next week. Okay, bye-bye.